Hello, everybody, and welcome to session 2 of the Completed Life Conference. I'm delighted to welcome you today for Clinical Points of View, which is a discussion between clinicians, Judith Zitter and Judith Schwarz, moderated by Hannah Lipman. Session 2 will address complicated clinical cases at the end of life and explore care options that can alleviate suffering. This session is designed to help clinicians optimize conversations with their patients at the end of life, exploring how clinicians can broaden patients' awareness of existing resources while they still have decision-making capacity. What remains meaningful to patients at the end of their life in different circumstances varies from person to person and between families. However, patients and their families often share the goal of managing painful symptoms at the end of life, where the underlying focus of alleviating suffering throughout the dying process is not inherently different. So I'd like to take a moment to introduce our speakers today. Dr. Jessica Nutik Zitter, MD, MPH, is a national advocate for transforming the way people die in America. She is Harvard and UCSF trained to practice the unusual combination of critical and palliative care medicine. She works as an attending physician at a public hospital in Oakland, California. Dr. Zitter is the author of the newly released Extreme Measures, Finding a Better Path to the End of Life. She is a regular contributor to the New York Times, and her articles have appeared in The Atlantic, Time Magazine, Journal of the American Medical Association, The Washington Post, and many other publications. Dr. Zitter's work is featured in the Academy and Emmy-nominated short documentary Extremis, available on Netflix. Her media appearances include CBS Sunday Morning, NPR's Fresh Air with Terry Gross, The Doctors, The Leonard Lopate Show, and a Dr. Oz special, quote unquote, The Death Show. A sought-after speaker, Dr. Zitter has presented at numerous venues, including the Commonwealth Club, the American Academy of Hospice and Palliative Medicine, California Coalition for Compassionate Care, University of California at Berkeley's Dean Lecture, and the Caring Coalition Conference. Committed to mainstreaming conversations about death and dying, Dr. Zitter co-created a high school curriculum on death education that won top honors in the Open IDEO End of Life Challenge. The idea was piloted at 2 Bay Area high schools in 2017 and is featured in a forthcoming documentary. In addition, Dr. Zitter co-founded and served as the first medical director of Vital Decisions, a telephone counseling service for patients with life-limiting illness. Judith Schwarz, PhD, RN, has been the clinical director of End of Life Choices New York and its predecessor organization, Compassion and Choices of New York, since 2002. She has counseled many hundreds of patients suffering from incurable and progressive or terminal illnesses and their families about end-of-life options and choices. She earned a PhD in nursing at New York University, where her research explored nurses' experiences when asked by decisionally capable patients for assistance in dying. She completed an MSN at Lehman College, a certification program in bioethics and medical humanities at Columbia University, and many years ago, a nursing degree at a hospital program in Denver, Colorado. Judith has taught ethics and healthcare law to nursing students, lectures frequently to professional nursing and palliative care audiences, as well as to lay groups, and publishes regularly in professional journals. She has recently focused her writing and speaking on the option of voluntarily stopping eating and drinking as a means to achieve a peaceful, patient-controlled death, and has become concerned about the need to complete an advance directive by those newly diagnosed with Alzheimer's disease. Hannah Lipman, MD, MS, is our moderator today, and she is the Vice President of Bioethics at Hackensack Meridian Health and Associate Professor in the Department of Internal Medicine at Hackensack Meridian School of Medicine. Dr. Lipman received her BA in Economics from Northwestern University and her MD from Columbia University. She trained in internal medicine at the University of Michigan, cardiology at Tufts New England Medical Center, and geriatrics, palliative medicine, and cardiology at the Mount Sinai School of Medicine. She earned a Master of Science in Clinical Research at Mount Sinai and completed the Montefiore Einstein Certificate Program in Bioethics. Dr. Lipman has particular expertise in clinical ethics, medical decision-making, bioethics education for a variety of learners, and bioethics consultation. And I am Sarah Kiskaden-Bechtel, the Program Director for the Completed Life Initiative, and I'm delighted to have you all here today. And I will turn it over to Hannah Lipman, who will moderate a conversation between our clinicians. And one last note, I'm delighted to also be joined by Nicole Natal, who is an esteemed advisory board member for the Completed Life Initiative. And so Hannah, take it away.
Thank you. Thank you so much, Sarah. I'm really, really grateful to be here in the presence of these experienced clinicians who are going to generously share their experience and some stories of their patients with us today. I think we're all in for a real educational treat. So the way that we're going to handle the conversation is that first Jessica will introduce us to her and her work, and I'll ask her some questions, and we'll have a little bit of conversation with Jessica, and then Judy will do the same. And then we're going to have a moderated conversation among the three of us, and then we'll open it up to your questions. So I really am interested to hear your reactions and your questions to our conversation. So please keep the questions flowing, and we'll do our best to answer them. So with that, I'll turn it over to Jessica.
Oh boy, well, such a pleasure to be here with all of you. This is a really fantastic conference, and I love the concept of a completed life. I don't think I'd heard those terms before being invited to speak here. So I just want to give you a little bit of a background on who I am and how I came to this work. I started out my career really as an ICU physician. I mean, I trained in pulmonary and critical care and really worked mostly in intensive care units. And I had been in practice for about 5 years before I ever even heard the word palliative, which was in the early 2000s. By that point, I'd really started to feel like I was a technician on what I call the end-of-life conveyor belt, where there was this default approach to just attach people to all manner of life-prolonging interventions without ever even asking if that was what they wanted. It was just this sort of factory-like experience. And I was watching as I was sending increasing numbers of people attached to machinery permanently through trachs and feeding tubes to long-term acute care facilities. And I really was starting to feel this rising moral distress that I didn't even really have words for, because this was really all that I knew about how to take care of patients. And in 2003, by really just complete luck, I had begun to work at University Hospital in Newark, New Jersey. And by, again, really rare chance, it had won one of 4 very highly sought after awards from the Robert Wood Johnson Foundation to enhance communication in the intensive care unit. 440 hospitals around the country had applied for this, and only 4 had won it. And this little public hospital that I worked at had been one of them. And it was the project was being run by an advanced practice nurse named Pat Murphy, a former ICU nurse who was now running what was called the family support team. Again, this would go on to become the palliative care team at University Hospital, run by Pat for many years and nurse-led to this day. But at that time, again, no one even knew what palliative care was. I joke about how many times I had to spell the word when I finally started understanding it myself. And there was a lot of initial conflict between Pat and myself, which I describe in a variety of locations. I felt, who is this woman coming in and telling me how to do this training that I've gone, for years to be trained in. And one day there was a moment that was just an epiphany moment, which I can describe to you at some other point. But I just realized, oh my goodness, I need to do this differently. And it just melted, and I became awakened to this world of palliative care. And Pat really took me under her wing. And thank goodness for Pat. I don't know if she's on this conference or not. I hope she is. And And I learned about palliative care, and this was in the day several years before it became officially recognized as a subspecialty by the American Board of Internal Medicine. But it was this approach where patients were really seen as people, as multifaceted individuals with complex needs that you couldn't possibly understand unless you created a relationship with them, and where honest communication was essential to the practice instead of this cold distance or possibly false hope that I had sort of been handing out as part of the way I had been trained. And I decided that I wanted to practice medicine that way. And I wanted to help patients through this strategy and philosophy take control of their own destiny rather than just be this technologist on this conveyor belt with the protocols and procedures that I had become so good at. And so I then went on to get my boards in palliative care medicine, and I began to practice at these two different areas of medicine, the ICU and palliative care. But the honest truth is they merged. In whether I was on the ICU unit, I was always incorporating palliative care into that work. If I was doing palliative care consultation service, I was always incorporating my ICU skills into that work as well. Sometimes it was confusing, but it always made so much sense. So I've worked the last 2 decades, mostly in public hospitals, consistently, caring for patients from disadvantaged communities who are often, as we know, overlooked by the healthcare system. And I will say that, the concept of a completed life is, as we know, very personal, but it's really also very dependent on where you come from and what your priorities are. And most of my patients really, I don't think, have the luxury of even contemplating that concept of a completed life. I mean, they're struggling day to day to get through. And if they're lucky, then their doctor might refer them to our service if they have very serious illness, whether it's inpatient or outpatient, to help them sort of strategize about how they want the rest of the time to go. Sadly, most don't ever get this option and are left to ride out their time on this end-of-life conveyor belt. And it's really extremely rare for us to ever have patients or families request our presence. It's extremely rare. It's happening a little bit more commonly now than it used to, but it almost never happens. And I will say that when we're involved in cases, things go differently. We had about 4 weeks ago, I was on service, and one of the trauma surgeons, who's a big fan of palliative care, came on service, and she said, there's 5 patients who are going to get trachs. And she said, I want palliative care on all of them. And once we got involved with those families, 3 of those patients were determined not to have wanted trachs and were allowed to have a natural death. And had we not been involved, they would have marched right along, get their trachs, and go to a long-term acute care facility. So I just want to say that if we continue to allow this default practice without some sort of intervention, whether it's palliative care or something else, we are doing a grave injustice to our patients. I will say, to just sum up, that we really don't see medical aid in dying, which became legal in California, I believe, someone can correct me, at the beginning of 2017 or 2018. Sorry, what was it?
5 years ago, I think.
5 years ago. We've had, I believe, 1 request at our hospital. Whereas down the street, at Kaiser, my friends have patients requesting this all the time. And they have a whole process and department that is created to very effectively help people through that process. But it's just an interesting point to understand that this is not something that is prevalent in all communities. So I just want to say, again, that I'm thrilled to be here. I think we all deserve to have a completed life, whatever that means to us. And let's talk about it.
Thank you so much. You raised so many interesting points. I especially want to wait until we hear a little bit from Judy to get to your points about the patient population and how that impacts the choices that they ask for, like you mentioned. But I want to ask you first, what do you think drives the conveyor belt? It's such a powerful image to think about medicine being practiced in that sort of algorithmic, automatic way, and it saves lives. I mean, if I need the ICU, I want to be there if it can help me. So I want to hear a little bit about that.
Yeah, it's such a fascinating concept. If you look at the history of the American hospital, and it was really in the 1940s 30s that people started to play around with ventilators for polio victims. And then in the 40s, we really had these heart, these iron lung machines that saved, I don't know, tens of thousands of people, maybe hundreds of thousands of people. But you might know that better than I do, Hannah. Lots and lots of people. And then, of course, we needed a place to put those machines, and we needed technologists to actually operate those machines. And so, thus was born the field of critical care. And then by the 60s, I believe every single hospital in America had at least one ICU. And as we go through the next several decades, this became almost, I don't want to put ICU down because ICU is something I believe in passionately, but the subspecialization of critical care became almost farcical. I mean, there's a gastrointestinal intensive care unit at several hospitals. I mean, this is becoming a real thing. But look, ICU medicine, the new targeted chemotherapies, all of these things are truly fantastic miracles that we have restored people back to life. The problem is we've just become so focused and enamored of this technology, and all of our human desires to avoid the realities of death and the fact that we are mortal creatures allow us to focus on all of these opportunities, and we have sort of lost this ability to connect as human beings. So I think that that's what medical schools have become. Some are trying to bring back in this relational experience and communication, but we got really off track.
And then the other question I wanted to ask you, you said you gave a little teaser about your epiphany. And I think it would be really interesting to hear more about that, actually, because it mirrors the work that you're trying to do to kind of have, all of medicine to have that same epiphany, to bring the holistic approach with the highly subspecialized life-saving approach. So I'd like to hear more about that.
Well, that epiphany, it was one moment. I mean, it had been building, obviously. And I remember coming home and saying, I don't know who that nurse is, but she's, making me feel, she's always attacking me. And there was this sort of rising tension between us. But one day I had a patient who was going into renal failure. This person was right at the end of life, metastatic cancer, acidotic, renal failure. Really, I knew that this patient really had very little time left. But the team said, her creatinine's going up, her potassium's going up, we need to do urgent dialysis. And it was my job to put that Quinton catheter in to do dialysis. So, okay. So we got all set up for it. It's a ritual, it's a ritual, getting gowned up and the sterile field. I mean, it's something that we really believe in and can focus on as something that we're doing and we're helping. And in this moment, I was just literally getting ready to insert this catheter in, and the patient was sort of in Trendelenburg with her head down and her legs up, the bed kind of tilted back. And my medical student was next to me. And Pat, I look up and there's Pat. She's standing in the doorway of this ICU room. She takes her hand up. She goes, pretend phone, call the police. They're torturing a patient in the ICU. And it was so powerful. It was a movie moment in my life, and it changed everything. I mean, I talk about this in my book. I went on to I did put this catheter in. I had no choice. That was all I knew how to do. And this happened so abruptly, but I couldn't think of a way out of it. And there's so many reasons why I couldn't think of a way out of it. But I came home and I couldn't sleep that night. And it was the next day that I went to Pat and I said, I'm ready. Teach me how to do this differently. The patient did die the next day, by the way.
Interesting to think about, that our medicalization of death has replaced, historic rituals around death and dying with, what you describe as very ritualistic. I hope we pick up that theme. Thank you. Thank you very much. I want to turn to Judy and hear a little bit about you and your work and go from there.
Hello, everyone. I'm delighted also to be a part of this, which I think is going to be a marvelous conversation between Jessica and myself and Hannah. And I would like to say right off the bat, I know Pat very well. We share many values in common. We've known each other for years. And she's marvelous, and she's a fabulous teacher. And I know you feel lucky to have met her professionally and every other way. So let me tell you a little bit about how I came to be where I am. I'm a nurse. And early in my career, I spent several years at the bedside of very ill patients in the intensive care units. I was a critical care nurse. That's what I did. I was really good at it. And I learned a lot about dying badly. We were really good at helping patients die badly. And then I went back to college and discovered bioethics and became immersed in discussions about whether there was a moral difference between killing and letting die. And I thought, oh boy, I'm all over this. I love this stuff. And I had a lot to say about that based on my experiences of being in the ICU. And then I had one of those life-altering experiences that, in retrospect, changed the trajectory of your very life. It was about 25 years ago, and a dear friend who had been living and working with a terminal illness for years called me and asked me to help her die. Now, I need to tell you that, of course, we were running partners back in the day. And I told her, of course, I would be there for her in whatever capacity she needed me to be there. I was her friend, and I loved her, and I would do whatever she needed me to do. So when she called me and said that she wanted my help in dying, I thought, okay, here's where the rubber hits the road. I got right on my bike, rode over to her house, and that was when I began to learn that if you think this is simple, you don't understand the problem. I thought that if I just got her pain under control and got her into hospice, then everything would be fine and she wouldn't want to die. Like I said, it's not so simple. It's not really about physical pain. Physical pain can be fairly easily managed. Existential misery, on the other hand, is much more difficult to palliate. Despite good pain control, she still wanted to hasten her death, and her husband and her 3 college-age kids supported that wish. I was pretty clueless back then and had little to suggest aside from home hospice care, which she grudgingly agreed to. She had a million friends, and I suggested that there might be some of them she might want to say goodbye to. She tried foregoing all oral intake, and for 10 days she fasted. And even after 10 days, although she was tired and she sighed a lot, she would get out of bed every morning and do the New York Times crossword puzzle in ink. She was very strong, both of will and of physical body. As I said, she was, I didn't say she was a marathon runner. I was not. Eventually, her family succeeded in helping her to die. I gave what little technical advice I had to offer, and I left after telling her I loved her. And I cried all the way home. I was not with her or her family when she died because I was really afraid about possible legal jeopardy. I had kids in high school and was a single parent in those days. Her husband called me the next morning and told me she had died peacefully. But I was unsure about whether that was so. For years, I've been unsure about that. And so that experience sent me back to college again to research how other nurses had responded to requests for assistance in dying. I must tell you, this was in the early 90s. There were very few studies at all about nurses' clinical experiences. If they asked nurses anything about assisted suicide, it was, what do you think about physician-assisted suicide? That was the question that nurses were asked. So completing that research and being steeped in that literature in turn led me to the work that I've been doing for the last 20 years. As Hannah said, or somebody said, I guess it was Jessica, I'm the clinical director of an end-of-life advocacy and support organization in New York. I'm the person that responds to whoever calls our call-in number. They leave me a message. Sometimes they tell me why they're calling, and they leave me a number, and I call them back. Other people email us because they've Googled, help in dying or death with dignity, and that's how they get our contact information. So I provide information about end-of-life options and choices to decisionally capable patients and their families who are living with incurable and progressive or terminal illnesses. I do a lot of listening. I do some exploring about issues and concerns, and explaining about realistic options. We discuss their hopes and their wishes and their fears about dying, and not surprisingly, they mention their fear about unmanageable pain in the future or an overly prolonged dying process, and their desire to avoid total dependency upon others. For some people, the idea of being in diapers is beyond anything they can bear. It's worse than being alive. So many of these folks, I can tell you, had no idea what palliative or hospice care is or how you distinguish them one from the other, and nor do they know how you get into either of those things. How do you get that? How do you access that kind of care? So we spent a lot of time talking about that. I also learned from them how they understand their disease and what their prognosis is, what their physicians have told them, and what their relationship is like with their healthcare providers. I asked them why. Why do you want to hasten your dying? And why now? What's changed? What's made you decide that now is the time that you need to take some action here? So these are long and very fruitful conversations. It's important, of course, to learn whether they have inadequate symptom management, because not surprisingly, if people are in terrible pain, they want to die. That's totally understandable. So, of course, the response is, let's get you out of pain, and then we'll talk about this. So often the desire to hasten death goes away if your symptoms are well managed and you have psychosocial support. We discuss whether they are dependent upon any life-prolonging interventions, particularly things that are implanted like cardiac defibrillators, things that can be turned off potentially, or medications that could be discontinued, and what the effect of doing that would be like. And encourage them to talk to their physicians about these options and what that would be like for them. I want to know whether they've completed an advance directive, and what kind of an advance directive, and how long ago was it that they completed that directive, and do they have a healthcare agent, and have they discussed these things with their healthcare team, and not just their agent, but all of their family. These conversations used to happen in patients' homes, but of course now we can't do that. So we're doing a lot of Zooming and we're doing a lot of conference calls. I always want to have somebody else in the room, on the phone, in the Zoom, because it's very hard to remember all of this stuff, and it's a charged conversation, and oftentimes we need to go over it all over again, which is just fine. It's understandable. Because I live and work in a state that does not have medical aid in dying legislation, I also have to inform many very disappointed and I would say shocked New Yorkers about that political reality. I can tell you most people would just like a magic purple pill that they could take and fall asleep and not wake up. I tell them that it's not that simple, and that doesn't exist. For those few individuals who find their current existence intolerable due to disease-related symptoms that cannot be adequately relieved, even with hospice or palliative care, their only legal option in New York State is to voluntarily stop eating and drinking. And as was mentioned, I've guided many, many patients and families through this process. There's a good deal that the patient and the families must learn about VSED, voluntarily stopping eating and drinking, before they can make an informed choice to implement that option. And the patient must be decisionally capable in order to do so. This choice requires considerable upstream planning before it can be initiated. And I'm happy, and I presume we will discuss more about that later. So I'll stop there, Hannah.
Actually, I'll pick up on that a little bit now. Can you tell us a little bit more about what kind of clinical guidance is required for voluntary stopping of eating and drinking, and why somebody would make that choice, and whether there are people who ask about that choice who are not good candidates for that decision?
This is nobody's first choice, I can tell you. VSED is nobody's first choice as a means to hasten their death. But in New York State, often there are no good alternatives. And in order to be able to be successful, and by successful, I mean a peaceful, relatively gentle death that occurs within a predictable period of time. If somebody's terminally ill, the fasting is approximately 10 days, sometimes less, maybe a little bit longer. The challenge is the fluid. It's not food, it's the fluid. in order to even begin to think about this patient must be extremely determined to hasten their own death, to control the circumstances and timing of their death. Plus, they need to be well informed. They need to understand what the process is, how long it will take. It's amazing. People think that if they fast for 2 days, then they'll die, which of course is not the case. So you have to have a well-informed, determined patient. You have to have caregiving support. You have to have usually round-the-clock care because these people become very ill, very weak rather. They can't get out of bed. So you need to have 24/7 care. You must have access to hospice and palliative medical oversight because clearly there are symptoms sometimes associated with the fasting, but often with the underlying disease that need to be well managed. And sometimes there are clinical emergencies that need to be addressed aggressively. So hospice will support a terminally ill patient's option of decision to stop eating and drinking. And that's, in my experience, there's no problem with that. But there needs to be also psychosocial support. There needs to be somebody who will journey along with this patient, who understands why they've made this choice. And even though they're sad about the fact that this patient is hastening their inevitable death, they understand why. And in my experience, most families who've seen their loved ones suffer want to shorten that suffering any way they can. So those are the things that need to be in place, Hannah. And I think you asked whether anybody ever starts and stops or if somebody's inappropriate. Mm-hmm. There are a lot of people that want to know about options and choices. That doesn't mean that they want to act on those options and choices. They may think they do. They may believe they're ready. But as many of us recognize, as death becomes nearer, life can become more precious. And in fact, you really don't know how you're going to feel or respond. And particularly if you're getting good symptom management, sometimes it's a lot harder than you ever thought to hasten your death. So my role is I have no agenda here other than to provide accurate and complete information to individual patients and families, and what they do with that information is entirely up to them. So many people have the option, they know about the choice, and they never do anything with it. But I can tell you that they're comforted by knowing they have a choice, that if things all of a sudden get intolerable and they can't stand it, they have some control. And for many people who have felt like they have had to give up so much because of their disease, that they have so little control over so many parts of their life, it's very psychologically, spiritually comforting to know that they actually can make choices. They can make decisions. And so that's what I do.
Thank you. I'm struck by this notion of control and by some of the differences between the choices that you're describing and the patients that you're describing and how they come to you from what Jessica was describing in intensive care units in a hospital setting before. Most especially that patients come to you, Judy, with a notion of what a completed life might mean to them. They're looking at, at the possibility of the end of their life, and if they've called you, they've already thought about what it means to try and wrestle that control. That's right. Sounds like it's different from your patient population, Jessica. So I'd like to just ask you to talk a little bit about the choices that are facing your patients and families, and if they, especially in the intensive care unit, have sudden illness, they don't come with that preparation for thinking about what it means to complete a life.
Yeah. I mean, it is so different to have a person coming autonomously, but on their own with this incredible drive to learn and control and create some kind of independence around how things are going to go, compared to somebody who comes into your ICU and is never or no longer able to talk to you, and you're dealing with their family. It's very, very different for a variety of reasons. First of all, from an ethics perspective, most families understand that most families do not want to do something that their loved one wouldn't want them to do. And the ultimate thing that you could do that somebody might not want you to do is in some way assent or consent to shortening or hastening, shortening their lives. So we have so many situations where families are standing around the bedside And many of the people in the family really don't think that this type of life that I might describe to them about a life in an LTAC, which is a very high likelihood at that point, and what it would look like, they don't think that the person, if they were standing there with us at that moment, would want that. And yet when you ask them, have you ever had this conversation? No, because most people haven't. And where does that leave you? So you think you know what the person would say, but how many people are actually going to work with the team? And it's, by the way, the way we do it in this country, because we're so much about autonomy, and autonomy is a beautiful thing. And it's one of the principles, the ethical principles that we work by. But the problem is that then this autonomy is transferred to this other person who has their own set of issues as the daughter, or unresolved guilt, or all sorts of things that may be going on, that where the autonomy isn't really necessarily theirs, and yet it's foisted upon them. And so people are completely unable to do that. And so what happens when people feel this perplexed, overwhelmed feeling? We all default to prolonging life. That's what the default practice will be. So, when someone comes and is unable to talk to you, that's a whole different issue, regardless of socioeconomic status, education. It doesn't matter where you come from. This could happen in any neighborhood in America. If you haven't had that conversation with your loved one. But then there are differences in preferences. And there's a lot of data that shows different choices that people make based on race, religion, et cetera. I don't think we necessarily know yet if it's because they are just truly different choices, or if there's other factors that we're not accounting for informing those choices, i.e. distrust of the healthcare system, which is a very important piece here. The fact that, frankly, there are tremendous racial inequities in our healthcare system that have been, since the beginning of this nation, a part of the treatment of African Americans and other minorities, has created an understandable situation where people just assume they're going to be deprived, neglected, experimented on, et cetera. And so with that distrust, you can just imagine that because we're Americans and more is better, that's what we see all around us, more technology must be better. And I think that may be a part of what is going on. But there's so many factors. Again, it's unique to each person and each family. I don't know if that answers your question enough.
Yeah, I have a follow-up, which is, are there some go-to questions, or, since, there are, in the part of the framing of our talk is to give clinicians some understanding about how to have, these conversations and provide better end-of-life care. Are there some go-to questions that or ways of eliciting patients' preferences and values that you use with patients' families to kind of bridge that gap that you talked about when families are trying to hypothesize about what a completed life and how the end of somebody's life should go? How do you manage that?
Great question. And I think the answer is this. For me, it's about the relationship. It's not a question. It's not yet a question. The questions come later. The first thing that has to happen, which we are not great at doing in the hospital setting, or frankly, I'm going to pick on doctors, but as doctors, I think nurses are a lot better at this, is showing that we care deeply, that is forging a relationship with a person as a unique, beautiful entity, and coming in, really doing our best to take away our judgments, our biases, and put it to the side so that we can get to know this person and show them that we care about them. And that, to me, in all my years of practice, it's the secret sauce of good medical practice, is really caring about somebody, even when you have to fake it at first, but really coming in and trying to put away all of those things to the side and really focusing on this person. And then that's when you can start to really get into understanding who a person is, what their preferences are, what's important to them. And if a person trusts you, or your team, by the way, I think the beauty of palliative care is that we're working as a team. And so there's so many different people coming in with so many different perspectives and competencies that and we have a diverse team. You know, I think that sometimes having people of color on your team, I think it's critically important. And we don't have that diversity in most places. And that's when you can start really getting to know somebody and showing them that you want to know what is important to them, and really getting into the concepts of completing their life the way they need it completed.
It's so interesting that you mentioned that. It's not an intervention. It's not a set of questions. It's a relationship. And I have a couple of follow-up questions for both of you on that theme. There was a conversation in last week's session about the notion of a good death and a completed life is, of course, it completely intertwined with the notion of living. And that relationship between that patient and the family with you as providers, both of you, is part of that patient's and family's living. So the notion of a completed life is intertwined with your relationship as providers. And I think that is really an undervalued aspect of the work that people who work in palliative care and end of life do. So I'll just turn to Judy for a second, if you want to comment on that and talk about the ways that you build relationships. It's different, as we said before, because people come to you looking for that information and that relationship in a different way.
It's interesting that you say that. As you were speaking, Hannah, I was thinking about the fact that I feel privileged to have the relationship that I do have with my patients. And that relationship often endures over months and sometimes even years. I'll get calls from somebody who will say, you may not remember me, but we last spoke 5 years ago and you said I should call you if anything changes. And so something has changed and I want to talk to you about it. So it's really important to me that I have the same phone number. I answer my phone. I give my cell to everybody that I've spoken to, and I answer every phone call that I get. And of course, I meet with people when I can. I couldn't agree more with Jessica when she talks about the importance of trust and mutual respect and honesty and openness about what you can do and what you can't do. People have different ideas about what's okay to expect from their healthcare team and their healthcare providers. I get calls from people who basically come to the end of the treatment train at big fancy cancer centers, and that cancer center says, well, good luck, see ya. Maybe they'll make a hospice referral, maybe they won't. And these people are like, what do I do now? What can you talk to me about? And I say, you know, the whole business of hope here still exists. And what we can hope for is what I refer to as the least bad death possible, which is let's figure out what's important to you. Let's figure out what you and your family would like to see. What is it that you most want to avoid? And let's see if we can put that together. Let's see how we can make that happen together. And I want to say one other thing, Jessica, when you were talking about your patient population. I have never had a patient of color, ever, in 20 years. And I think that's sad because I think that we provide a service that people of all perspectives might want to know about. And we're trying now to consciously reach out to underserved populations as an organization. But it's a huge challenge. And in lots of ways, I envy you your diversity.
Well, can I respond to that? Yeah. I mean, it is an interesting question, an interesting point, and I think, and I've had several situations in the hospital. It's interesting, and where my population doesn't know about VSED, or they don't know about medical aid in dying, and there have been a few cases over the past 5 years, where I thought, oof. This is a situation where we are not going to, even with the best palliative care and hospice, be able to help this person with their tremendous suffering.
Yeah.
And And I think, oh my gosh, if this person knew about medical aid in dying, they might ask for it, but I'm not going to tell them about it. So again, it's an access issue, and it's really a conundrum.
Yeah. Because I think you have to be careful that you're not too far in front of your patients, right? Just because you know about options that you think might be helpful, you have to be very careful about whether or not you assume responsibility for laying that on them when they're perhaps not ready to hear that. So it's a very careful dance that has to happen.
Yeah.
You can jump in anytime, Hannah.
I was just going
I can respond to that, but
I was going to ask a follow-up, and you feel free to respond in any way you want. But the question that popped into my mind is when you said you're not going to tell people about medical aid in dying, and I work in a state where it's legal, but newly so. And as an ethicist, I'm asked the question: is it a required part of an informed consent conversation about end-of-life options? And that's tricky, and I'd like to hear, as a practitioner facing that question, how you manage them.
Yeah. Can I respond, or are you asking me? Or well, I'll tell you, this is an interesting question because I don't tend to, unlike Judy, I don't tend to have conversations about end-of-life options. It's really rare that is a conversation that would happen. I'm going to tell you about your end-of-life options. Just about 2 weeks ago, maybe 3 weeks ago, we had a patient who came in from a prison and who ended up, who had a pulsed form and came into the hospital with COVID and I've heard this story has happened so many times. It's really quite alarming. It wasn't at our hospital, it was another hospital in the locale. As this person deteriorated and became more and more hypoxemic, the doctors got anxious, as we do, and said, I really think we should try, this is a weird infection. We don't know. And the person got intubated. In fact, his wife told me that he felt so much pressure to do this that he signed the consent form to get intubated and threw the pen on the floor. So when I got involved, as this wife was getting more and more distressed and we were called in, we talked to her about the alternative of extubating palliatively, not palliatively, but just taking the tube out and allowing this person to die. And I said, had you ever had anybody talk to you about different alternatives that we could have, not intubated him and given him morphine and kept him comfortable as he was becoming more and more increasingly short of breath? And she's a nurse, by the way. This was interesting. She said that was never presented to us. And if that had been presented to us, we would have taken that option. And now she's got this husband who's on a ventilator and she's got to make this choice for him. And the frustration was so palpable and so painful to watch and to hear about that we don't provide people with alternatives a lot of the time. And we certainly don't have conversations, at least in my environment, here are your options for the end of life, because that's not the way those conversations tend to go.
I tell you, I say to my patients and families all the time, most people are terrified of, even before COVID, ending up in an emergency room and people jumping on their chests and putting tubes in them, right? And the only good news about all of this is anything that's been started can be stopped. Anything that's been put in can be taken out. But, you do have to show up with the documents, because just because a family member says, oh, she would never want this, doesn't mean anybody's going to be able to act on that. I can't tell you how many times I get calls from, almost always, the daughter of somebody who's been in a nursing home for who knows how long. And most often, they're not being pegged anymore. They're not getting tube feedings, but they are certainly getting hand fed by a very patient aide who's very skilled at getting the glop into the mouth and encouraging them to swallow. And so I get calls from the daughters saying, oh my God, she would never want this. This is no life. She can't speak. She can't move. She doesn't recognize me. She is not the person she was. That person has left this shell of a body. What can we do? And I say, nothing. Nothing until she starts coughing and choking, and then the burdens of continuing this treatment outweigh the benefits. And it's heartbreaking, but that's the reality. That's the reality. Unless you've had a conversation of some kind about the kind of interventions or the kind of existence you would find intolerable, it's so hard for family members to withdraw, to stop something that is life prolonging for all of the reasons that Jessica mentioned. It's psychologically so much harder to withdraw something, even though I said you legally and ethically can. Psychologically, it's much harder to do that, and we all know that.
And let's not forget that artificial nutrition and hydration, and even a glop of food put into a mouth, is a form of life-prolonging treatment.
Oh,
but the problem is, the problem is that human beings see food very differently. And I'm not even talking food, I'm talking about liquid calories differently than they see a breathing machine, because food has a whole meaning of caring and sustenance and nurture. And so it's a double whammy to talk about withholding or withdrawing something that is associated with love.
And the notion is that by doing so, by starving somebody to death, you're causing them horrible pain and suffering.
Yeah.
So it's not only that you're not providing this psychologically and familial comfort, you are causing them pain for sure. And there are also, of course, cultural issues, right? Some cultural traditions see food in a much more powerful way than others. And so it's indeed a tremendously challenging, powerfully charged decision.
What's about the go ahead, and then I'll jump in.
I'm just going to give you a little color of a story. Again, these are all like in the past few weeks, but we had a patient, and this is not unusual. This happens all the time. A patient with some sort of pelvic cancer or GI cancer, I can't remember what it was, causing a full, complete bowel obstruction. She had intermittent bowel obstructions on and off. They'd always kind of resolved, and then the food had gone through again. But this time she came in with a bowel obstruction so profound that she was vomiting. I mean, I hate to say it, but vomiting feces. It was horrible. She came into the hospital, got an NG tube, got decompressed. They stopped feeding her for a while. We gave her all the medications that we try to give to restart the bowel flow if we can, and it didn't work. This was a full-on end-of-life bowel obstruction. It was a terminal event. And so this woman, who was Chinese, wanted to eat again after a week or so. She wanted to eat. She thought it would make her stronger. There was no food that was going to go through, nothing. We had talked to the gastroenterologist, the interventional radiologist about putting in different kinds of bypasses, and it wasn't an option for her. And so the question is, what do you do in a situation like this when someone's culture makes them believe that eating is such an important part of staying alive, and yet you're telling them you are never going to be able to eat again. You are going to starve to death. It's a conversation, especially in different languages, that is so complex, so painful that many doctors just say, give her clear liquids.
Yeah,
and
right.
it's really complicated.
Yeah.
Yeah, I mean, that's a good segue to what I was going to jump in and ask, which is, that it's not only the cultural and emotional issues around food, in most other contexts, feeding, especially the feeding that the kind of feeding you're talking about, Judy, which is, relationship driven, there's somebody standing with the person feeding them. It evokes an image of care and support. And it's interesting to think about under what circumstances that how you think about, shifting the circumstances from when that is care to when it isn't, right? And Jessica mentioned one in which that it's just, not physiologically possible for that food, to help this person because of their actual physical obstruction of the bowel. But the patients that you're talking about, Judy, are slightly different. That's not necessarily the case. So how do you help people think about that, the circumstances in which feeding is care or not? And I'm not saying that everybody subscribes to that notion that there is any circumstance in which feeding is in care.
Well, as I said at the outset, I've been doing this work for really a long time, and I'm accustomed to getting calls from patients who have clearly terminal illnesses, cancer, ALS, end-stage Parkinson's, and there's a pathway that you follow about symptom management and wishes and goals and that sort of thing. But recently, I started hearing from a group of patients I have never heard from before. And these were people who had just been diagnosed with an early stage of some kind of dementia. And they were absolutely terrified about what was going to happen. And usually these were people that had some kind of family history. They'd seen members of their family die badly, in their view, of end-stage Alzheimer's or other forms of dementia. And they were absolutely adamant that they wanted to know what they could do to prevent that. And of course I said, well, look, if you're decisionally capable, which people who've just been diagnosed with a dementia of some sort are, you can always stop eating and drinking, and that would allow you to control the circumstance. But I said, it's tough. You're not terminally ill. It would be a challenge. And there are lots of things, lots of conversations we'd have to have about whether that would work. And they'd say, absolutely, that's what I'm going to do. You bet. I'm going to watch that window of opportunity, and I recognize I have to make this decision while I'm still decisionally capable. Well, I've never had one patient do that. They say they're going to do it, and they haven't done it. And I think for a variety of reasons, it's not just that this is really a hard thing to do, to give up a life that still is giving you pleasure. I think there are things that happen along with not just the short-term memory loss, but it's the executive function, right? To be able to make a plan and carry out that plan. It doesn't matter whether your family's supporting you or reminding you. If you can't get it together, you're not going to do it. But what we have been able to do, at least in New York, is create this thing called the Dementia Directive. I don't know whether you wanted to talk about this now, Hannah, but I think
sure. Tell us about it.
Yeah, I think it's an interesting concept because it allows people who know what that final stage of Alzheimer's or other forms of dementia are going to be. They're going to be in a bed. They're not going to be able to walk independently. They're not going to be able to speak more than 3 or 4 words. They're not going to remember any of their loved ones or have a conversation with anybody. And they will certainly be in diapers. And they say, I don't want that. What can I do to avoid that? Now, I find it fascinating. Most people think that if they check the box that says, I don't want tube feedings, they're good to go. But that's not how people die anymore with Alzheimer's. They die eventually of aspiration pneumonia because somebody's been spooning glop into their mouth and they forget how to swallow. So this dementia directive allows them to decide when they would want to limit oral hand feeding, whether they want to limit it completely or whether they want to focus on comfort-focused feeding, which is just small amounts that seem to provide comfort, but nobody's talking them into or coercing them into eating more. And you have to identify at what stage you would want that to happen. And certainly it's when you've lost decision-making capacity, you can no longer feed yourself, and both your healthcare agent, which you must have, and your physician agree that you're in an advanced stage of dementia. I can tell you that hundreds of people have completed that document in New York, and people call me from all over the country, actually. And I tell them, and it's true in New York, I don't know whether it's, quote, legal, because it hasn't yet gone before a judge. We see it as an advance directive to stop eating and drinking, like any other advance directive that says, I don't want this life-prolonging intervention under these clinical circumstances. Indeed, it will go before a judge at some point. We're hoping that the judge will see it our way. There are lots of really smart people across the country who are thinking about advance directives to stop eating and drinking, to limit oral intake. And it's been a really interesting journey that we've been on together. I have one patient family that I've been counseling now, Jessica, for 4 years. We meet every 6 months. He and his 2 kids, 2 daughters are on the phone, the 2 sons are here, and the wife. And this man has said, listen, when I get to stage 5, 6 of on the functional assessment staging test, I don't want any oral intake. I just want aggressive palliative care. I want to stay at home. And even if I demand food and fluid, even if I ask you for food and fluid, just ignore me and don't give me any food or fluid. And I have been trying now for 3 or 4 years to get him to see how very, very hard that would be for any family member to say, we're just going to ignore you, even though you seem to be suffering and you're hungry and thirsty and you're asking us to give you something to eat. My role is always to say to family members, you don't want to become the food cop, you don't want to become the fluid cop. You want to be able to provide the least amount of food or fluid to keep them comfortable. But this is a hard one. So every 6 months I see, okay, so tell me what you're thinking now. How are things going? What's your disease like? What are you feeling? So it's interesting.
You mentioned that hundreds of people have filled out this this dementia advance directive. Have you had cases where it's been implemented? You're talking now about some of the complexities of implementing it.
Not yet, Hannah, because all of these people were in the very early stages of dementia. Right. Mild cognitive impairment. I got that. I swear to God I do. So it's early days yet. And I hope that I will hear from family members as to how this is going. I certainly encourage these patients and families to talk to their primary care physician, their geriatrician, their neurologist, their their family attorney, and all of their family members, not just their healthcare agent, and to do a videotape of themselves saying why they've made this choice, what the circumstances are, who they are now, so that those aides that are caring for that person in the bed later will understand that this was their choice, not their family that's saying, I'm tired of taking care of this person, right? So it's an interesting process. I don't know exactly how it's going to unfold, but I can tell you it gives those people some feeling again of control over avoiding a prolonged stage of dying, which, as you know, can last for months and years if you're getting good care. So
there was an interesting conversation again also last week for those in the audience who attended the conference last week and this week about the problem of advanced directives with the past self versus the current self. So that's why I asked about that, because the current self may want to drink and the current family wants to drink. And I wanted to turn to Jessica to respond to all of that, but to also ask you to talk about a little bit about conflicts that come up about advanced directives. In your work, Judy's talking about a very specific sort of advanced directive, but more generally, if you had anything to add on that.
Well, I think it's really important. One of the things I wanted to actually ask Judy is, and we're not there yet, but this question of, advanced directives are a guideline, right? They're really not any doctor's orders. They don't tell anybody what they have to do. Right. They're a guideline for them, for the person and for family to sort of hopefully present self still feels the way the past self, but at least there's some kind of an inclination. Most of my patients don't know what an advanced directive, haven't done an advanced directive. I don't see a lot of advanced directives. Every once in a while we have them. And so my question for Judy was, well, wouldn't you eventually want your goal be to have this concept for families and patients who agree, this is the way I would feel even if I am asking for a drink and fluids, to put that on a POLST form so that it's actually a doctor's order that allows people to actually stop, because it becomes very complicated.
In New York State, there's a line I think everybody's POLST is a little bit different because they're state documents. In New York State, in the section where you talk about the level of care you want, aggressive or semi or a trial of care or comfort care, right? If you're asking for comfort care in New York State, it says, we will, of course, offer you food and fluid as you choose to have it. So I tell patients, scratch that out and say, see my attached dementia directive about hand feeding. I'm refusing hand feeding if I should become permanently cognitive impaired and unable to decide for myself or feed myself. It's very complicated, Jessica, because many physicians have never even thought about this, right? And frankly, they don't want to think about it. You know, it's like, oh my God, something else that I'm going to have to be involved in. Now, it's not always the case, and geriatricians tend to be considerably more understanding. Neurologists, not so much. You know, I don't think that they spend the time with their patients that geriatricians do. But in any case, it's certainly, it's so much more helpful to have for family members to know what this person would want you to do on their behalf. I mean, I really do buy into the benefits of substituted judgment. If you don't know what the heck this person wants because you've never discussed it, you're going to be in that waiting room outside that ICU for months, right? For months and months, because what are you going to do? But you're going to treat. And you get on that treatment train and you can't get off.
Right. So one of the things, one of the analogies I'll tell you that we see in the ICU a lot is that has to do with the importance of talking, and ideally upstream with you in some capacity, but even in the ICU about the artificial nutrition piece of it. So if somebody is on a ventilator, they have a very poor neurologic prognosis or a poor cancer prognosis or whatever it is, and the family has said, we think that it's time to take the tube out. We understand that she will die. Yeah. One of the things that I put into my practice always is a conversation about food. Because if you're doing an extubation for somebody who's not going to ever be able to really wake up and take oral food, and who has an NG tube in, for example, or an orogastric tube in with the endotracheal tube, it's really important to prepare the family that when that tube comes out, many patients may stay alive for a period of time. And families become increasingly agitated over day 2, day 3, when they start to say, well, wait a minute, aren't we going to feed her? Because they know that the NG tube's been taken out or the OG tube's been taken out. Yeah. Are you guys going to feed her? And so I find, and I have actually never found this to be to cause any problems. If you talk about it in advance and you say, I just want you to understand that the off chance that she lives longer than we think she will, we are not going to restart artificial nutrition because, again, we understand the goals here. They will not support them, and she will not, this will not be consistent with her goals. And so it's really an important thing to have that conversation because, again, it's such an emotional point that people can get so panicked about. And can you imagine someone's been extubated, they're going to die in another 3 days, but the family's starting to panic that you're starving them? And if you have that conversation in advance, people really are okay with it.
Do you know the other thing that I do, Jessica, that reminds me of that conversation is I actually talk about dying. I actually say to families, well, you know your mom's dying, right? Because if you're not able to have that conversation, you're not going to be able to have the palliative goals of care conversation. If you still think that, we're just not going to look at it, it's not going to happen, we should keep feeding, doing this, doing that, you're never going to get to the point of how can we make this better for mom? How can we help not just mom, but everybody else take advantage of this precious time that you have together, right? So it's astonishing to me how often patients will come to me, call me, contact me, we'll have conversations. And one of the things that they'll say is, nobody ever told me. Nobody ever told me. Yeah. Do you understand what it means when they say that it's a palliative intervention? Do you understand what that means? Well, no. What does that mean? So, there's so much disinformation and lack of communication that these poor folks, of course, can't make informed and thoughtful choices for themselves.
I say, you cannot plan for a good death if you don't know you're dying.
Exactly.
And another thing that strikes me about this interchange, I've always said, and if there's anybody in the audience who knows me, they've heard me say this. If I had a button to wear on my uniform, it would say goals, comma, not interventions. And so one of the themes that you're both actually bringing out is that idea that you pull back from this discussion about a feeding tube or about any specific thing and build relationships and talk about goals, and then you go back down to the deeper layers about the interventions.
All of those decisions about antibiotics, yes or no, artificial nutrition, yes or no, extubate, intubate, they all trickle out of that high level relationship and then goal setting conversation. The answers then fall out on the ground. They're there for you.
Yeah. And that whole notion of having a conversation around goals of care and the fact that they can change, right? They change over time, of course. And that's okay, as they should. And let's acknowledge that. Yeah.
It's a segue to we're going to turn to Q&A in maybe 5 or so minutes, but I wanted to pull us back to this notion that came up in the beginning about the ritualization of medical interventions, and how and Judy mentioned kind of a ritual of feeding. If it's not serving a goal, it turns from care to something else. But so I wanted to ask each of you, maybe Jessica first, what rituals you replace those medical rituals with when somebody is dying in the hospital. How do you kind of demedicalize that setting?
Oh, I'm so glad you asked that. You know, I work with an amazing chaplain. I have worked with her for 10 years now, Betty Clark, who really is my next mentor to Pat. I would say that as a doctor, it's ironic that my two most important mentors have been a nurse and a chaplain, but it's true. Betty, it took about, I don't know, maybe 5 years of us working together before Betty finally got me to stay in the room when she started praying with a patient. No joke.
I believe it.
I had all sorts of reasons why I shouldn't be there. Well, I have a lot of other patients to see and I got to run. And, you know, Betty can do that part. She's better at it than I am. It would be weird for me as a Jewish woman to be in the room with people praying as to their, I just had so many reasons. And one day, Betty just said to me, let's pray, shall we? And she took her arm and she literally prevented me from walking out the door. And I didn't know what to do. But I kind of closed my eyes and was there. And at the end of this moment, I felt something different. And I have to say that since then, I pray with anyone whenever I can. It took me a while. I mean, I built up to it, but it is the most beautiful thing to connect with someone on their terms. And we know that, 94% of people consider themselves to be spiritual beings. 71% of them are actually affiliated with a religion, with an organized religion. And yet, do we doctors talk about religion, spirituality? No, not only because we're uncomfortable, but because we think it's going to make us feel less than. Somehow we're not as scientific. We're not as tough. We don't have as many answers if we're relying on this kind of touchy-feely, whatever. I don't know what's going on exactly, but I know for me that it has been one of the most beautiful ways that I have learned to connect with my patients, and one that I know is so meaningful to them and makes them feel so appreciative of my presence. And I often, I call Betty a surgeon of the soul. I mean, she is somebody who gets in and connects with people in some of the most important ways that they need to be connected with. So that would be one of them. I can think of many others, but certainly that's one of the most important.
Thank you. I'll ask, Judy, do you want to respond to that, or can add to how you kind of make new meaning and ritual when with your patients?
I don't have any of those similar experiences that Jessica's describing. I have been certainly at the bedside of dying patients, and I am very comfortable being present and remaining present. And I think that can be challenging also for clinicians who feel like they should be doing something rather than just being there. Mm-hmm. And I certainly am fine with that and comfortable with that. I also am very conscious, though, of not wanting to intrude on this very special time between patients and families. So it's something that I try to be really heightenedly sensitive to see what the needs are and whether I can be helpful or whether I should just sort of pull back and be, in a corner. But I think that's a wonderful story, Jessica. I love that.
You're mostly at home, right? Your patients are mostly at home. Yes. Yeah. So it's very.
This is in an ICU with our alarms going off and beeps and all like that.
Oh yeah.
Wow.
Oh yeah. Oh yeah. Absolutely. Absolutely. And it's interesting, in the time now of telehealth, and I know Michael Fratkin's on here somewhere. But it's Michael, go telehealth. But, it's really interesting because I also, Judy, it's really important to be sensitive to your presence in a room of grieving people, maybe people like with COVID who haven't seen their loved one for 3 weeks and are filled with emotion. And all of a sudden you've brought the iPad into the room. And sometimes I'm actually not in the room. I'm also being brought in on the iPad on the Zoom. And so it's this question of sort of how do you, what kind of presence do you want to have there? You're on a square with the rest of the family. And there's maybe a lot of weeping and a lot of emotion. And what is your role? Do you turn off your video at that moment? Well, that seems weird. And so it's really holding space on the Zoom is a really interesting skill as well. And it's one that I'm trying to figure out. I mean, this is all scrappy new stuff, but it's really complicated.
Yeah. Well, this is, I can't relate to that. Although I think it's wonderful, isn't it? Technology can bridge some of this horror of COVID. But I want to say one thing, Hannah. I have not had one call from a COVID patient, not one, which I find fascinating. And I have, speculated about why that might be. Okay. Yeah, Hannah. Jessica, go ahead.
I really think this is an important moment to talk about COVID. And what has COVID done to us all?
Yeah.
We're living in a plague. I mean, we've never, I don't know, have we ever experienced anything like this before? Well, the fact that in California, our skies have, the apocalypse is upon us is a whole other thing, which adds to the whole, the drama of this all. This is a dramatic moment. We've all been waiting. We waited for this tsunami. We're waiting for the second tsunami of COVID. People are afraid. People don't understand it. Doctors don't understand it. Patients don't understand it. Everything is changing in moment to moment, and people get panicked. And when people get panicked and emotional, you don't need just a pandemic, because this happens without a pandemic too. But when people get panicked, your decision-making skills go out the door.
Totally. I agree.
So I think
then you want to stay alive. You want to stay alive.
Exactly.
Although on the other side, I'm kind of surprised that patients that you described, Judy, before at the early stages of dementia, kind of trying to organize how they'll have control, or with, even with cancer that's being treated with life-prolonging or disease-modifying treatment, aren't seeing the hospital as not an option.
Oh, they're not going to the hospital. They're staying home and they're dying on hospice sooner than they would have otherwise, because they're not getting those preventative and follow-up treatments. What I have had in the way of COVID-related calls, a huge number of calls from people who really want to have a tight advance directive. They really want a document that's going to work. So I'm hearing from people and spending literally hours on the phone explaining the differences in the language and how you talk to your physician and what you need to do and what you shouldn't do and how you might think about this and what are the options. So that's the COVID related intervention that I'm seeing here in New York City.
We have so many great questions coming in from the audience. I think there's a lot more to say about the impact of COVID. There's so many more questions I wanted to ask each of you, but I really, really want to hear from the people who are listening in and connect with them. So we are inviting back Sarah, who's going to read some of the questions.
Hi, everyone, and thank you, Jessica and Judy and Hannah, for such a rich discussion. So I'd love to start with a question from Dr. Michael Libertazzo. He asks, as a psychologist at a hospital hit hard by COVID, I ask what might be offered kind of pre and post to doctors, hospice nurses, chaplains who are struggling with their ambivalence related to participating in a patient completing their life, how they live with any moral distress, and how the last case they participated in may affect their next case. I typically am asked to do debriefing groups with medical staff after the case, and am now curious, does anyone know of any psychological pre or post briefing groups that might be helpful to clinicians, hospice nurses, chaplains, etc.? Thank you.
That's yours, Jessica.
Wow. I apologize. Is this specifically relating to COVID?
Seems like it is.
Pre or post? I don't think I know of any. I don't really know. I'm still not sure I totally understand. I wish we could have him on to clarify the question a little bit, but no, I really don't know of anything specifically COVID related, but even not COVID related, that I'm assuming it's debriefing for the healthcare providers who are caring for patients. Right. And I will say, there should be. I mean, this is the point. This is what continues to fuel the end of life conveyor belt, is the fact that we are not processing our emotional distress. We are not processing our ethical questions. The best that we can do when we're stressed is go to the ethics committee. And that's not the point of an ethics committee. We are looking for moral support, and we need it in order to continue to carry on and do this really difficult work in the most humane way that we can. And we don't have those types of things. I mean, some places are starting to get, psychologists on staff. We just got one about a year ago. She's fabulous, and she's booked all the time for people to reach out to when they're feeling distressed. But there isn't anything organized that I know about, and there should be.
And so, Jessica, I would add to that, people are afraid for themselves. The healthcare team, the treating team in this plague, right? We think we know how to keep ourselves safe, but that's a part of this whole horror before and after. Maybe you've gotten COVID already and you're worried about getting it again. I mean, there's all kinds of stuff that's not been, and you're right, processing takes time, and debriefing should be done. And who's got time for that, sadly?
Dr. Libertazo is a little bit from my neck in the woods, and I happen to know the bioethicist at the hospital where he's listed as working. So I'll try and connect afterwards. I mean, we're certainly doing it in my hospital network, some COVID debriefing and stuff like that. But as you say, it's kind of, depends on the institution. In our area of the world, we got hit very, very, very hard. So the moral distress that the providers are feeling is really palpable, and palpable everywhere. That's a great question. Thank you.
Great, thank you. So another question, more pointed to Judy, but I open it up to you, Jessica, and you, Hannah. This is from Aubrey in Corvia. She asks, can you talk more about upstream prep for voluntarily stopping eating and drinking for those with progressive neurodegenerative diseases, such as Alzheimer's? Decisional capacity is vital in these instances. Is there clinical guidance available to help a person know when to start the process of VSED before decisional capacity is lost? And she has follow-up questions that are more broad that I'll offer as well. And are you familiar with end-of-life doulas? What do you think about this role being the psychosocial support in part necessary for stopping eating and drinking voluntarily? Would you recommend any protections for those wanting to serve in this capacity but not wanting to be held liable?
Okay, so I'll start at the bottom and maybe get back up to the top. I personally don't have any experience with doulas, death doulas. I understand they are an increasingly useful presence, particularly for patients that maybe don't have a lot of family support or psychosocial support, which is certainly a necessary part of any successful VSED process. The thing with people who have any kind of permanent loss of decision-making capacity, whether it's through dementia, whether it's some kind of traumatic brain injury, but the issue is, can they put into place a decision while they're still decisionally capable that requires good information, understanding the process, that it occurs over time. It's a process that takes patience, that you need to have caregiving help. You need to hire those clinicians before you start fasting, because lots of aides that do this work have some moral objections to not feeding patients. So you have to be sure that they understand that this is the plan of care, and that if they're going to take this case, this is what's involved, and it's important that they understand that ahead of time. So it's important that if that person isn't eligible for hospice, God help us all, it means somebody's made a guesstimate that you're going to die in 6 months, right? You may still be able to get symptom management palliative care through a long-term family physician. I mean, this is not rocket science. We need a little morphine, we need a little anti-anxiety medication, and we need to have access to Haldol if you go through organ failure and you become delirious at the end of life. So certainly a physician can order those medications, instruct the patient's family as to how to provide them, which happens with hospice anyhow. It's the family that's giving this stuff. So the challenge is that window of opportunity for sure. And you need to have other people who will confirm for that patient that the window is closing. It's very hard to be self-aware. It's very hard to be knowledgeable about what you're losing cognitively, because we all have our workaround solutions, right? So it's a challenging process. And if people want to get in touch with me by email, I'm happy to talk more about this or arrange a phone call, because this is complicated stuff and it's hard to just be succinct.
Should we also mention that one of the later sessions is going to be on is going to address legal issues?
Yes. And thank you for mentioning that, Hannah, because a decision-capable person has every right to decide what gets put into their body. There's no question about that. They legally have that right. And there is absolutely no legal jeopardy that accrues to anybody that's there as a psychosocial support or caregiving help. There is no legal jeopardy to that at all. Doesn't matter whether you're going to inherit their estate. I've heard that from some family members who are fearful. However, once that patient loses capacity, you have to have clearly written instructions that this is what the patient would want. Otherwise, it can get complicated. And that I know is going to, well, a book's coming out, Hannah. You know that book, the book that we've written about stopping eating and drinking, and the stopping advanced directives to stopping eating and drinking. There are a bunch of us that are co-editors, and this book is going to come out in the spring, and I think it's going to be very useful to many people. Oxford University Press is bringing it out. Okay, sorry.
So everyone, thank you, Judy. Thank everyone. The book that Judy mentions is listed in our conference brochure, so be sure to check that out. We'll publicize both Jessica and Judy's books on our Slack discussion board, so you have a direct link to find those. The session that Judy mentioned and Hannah mentioned about stopping eating and drinking, the legal ramifications for policy, is coming up in session 6 of the conference on October 8th with Thaddeus Pope and David Grunwald. So look forward to that. So Jessica, I wanted to offer you a chance to respond before I jump into another question.
Well, I think Judy did a beautiful job, actually, and I just learned a lot through this. This is really fascinating to me. So, but you know, there were two things I wanted to bring up. I think this issue of caregivers and caregiver preparation is something that is very important. I'm particularly interested in it now that we have a movie coming out about caregiver burden called Caregiver: A Love Story. And I learned about I'm embarrassed to tell you this, but I'm going to tell you anyways. I learned about caregiver burden really by making this movie, which was not what it was intended to be. It was intended to be, like you said, Judy, we in palliative care think we can always make death great.
Yeah.
And you had your experience realizing that you can't always do that, and your sort of medical aid in dying toolkit and VSED toolkit. For me, one of the things I hadn't realized until I saw the rough cut of this movie that we made was that actually you can watch a family member deteriorate quite rapidly even when you have a wonderful hospice on board, and the caregiver burden is very, very, very important to consider. It's something that we are not thinking about. Even, I would take the liberty to say, in the palliative care movement. I've been practicing palliative care for 10 years and sending lots and lots of people home on hospice to have their completed life. And they bounce back in because the caregiver is burdened. And so I think, and it goes along with this issue of VSED, and you have to prepare and think. It's part of the advanced care planning process. In addition to thinking, do you want life-prolonging treatment, yes or no? Do you want to remove life-prolonging treatment, yes or no? You also have to think, have you gotten your caregiver situation figured out, in place, and organized in a way that's going to be sustainable for your family?
It also ties into the conversation before about inequities. It struck me when, Judy, you said, in order for a patient to choose VSED, they have to have 24-hour care, and that caregiver has to be prepared to give enough to alleviate symptoms. But, all of that stuff, that's an enormous burden. So it all ties together. And as you're saying, Jessica, you have to have this lined up. Well, who in our society can line that up? I'm not even in that category, actually. Of people who really have somebody out there who can do 24-hour care at the end of life. That's an amazingly narrow piece of our population that can really line that up.
Yeah, I spent a lot of time telling daughters, no, you can't do it all. No, you have to have help. You cannot be on call 24/7. You have to be able to go outside and walk around the block. So,
Thank you all. So we have a follow-up question from Linda Weiselquest, and she asks, what about VSED in nursing homes or long-term care facilities?
Oh, dear God.
I've read at least one case where the patient wanted VSED and made that clear to the facility that she was moving to, and they're not agreeing to follow through on her wishes when the time comes. And she linked to the Washington Post article on Susan Sarin. I was wondering what your thoughts were.
Our patient, Susan Sarin, yes. It's a hell of a problem because, again, this is new for lots of people, and it's certainly new for long-term care facilities who worry about getting dinged by the folks that come in and inspect to see that nobody's losing weight. Because if they're losing weight, it means nobody's feeding them. We have to make a distinction between somebody who is decisionally capable and who gets to decide what gets put into their body and who doesn't. So the first thing is that decisionally capable patients in any setting, except perhaps a Catholic setting, let's be real here, have every right to stop eating and drinking and to be given support through that process. And often what's required is a lot of negotiating between the administrators, the risk management, the legal people in the nursing home. Some nursing homes or some assisted living facilities or these high-end senior centers will say, we are legally required to put the food in the room. Now, what you do with that food is up to you, which is really hard. Somebody who's trying to fast to have the smell of food in there is almost abusive. I've had patients' families who made a point of being there for every meal, and the family member would eat the food, to get it out of the room, but not to have to fight with them. They couldn't take care of their dad at home. So there are workaround solutions that can be put in place, but you shouldn't have to, but you do. It gets much more complicated when you have somebody with sliding capacity or who's beginning to lose capacity. And frankly, they can't remember what they wanted before. So anybody that opens their mouth when a spoon is put to the corner of it, and even if it's a reflex and their mouth opens, those nursing home facilities will say, we have a duty to feed anybody that seems to want to be fed, unless there is a completed advance directive saying don't feed me. But it's very complicated. Because these are early days, very complicated.
As a bioethicist listening to our conversation, and there was some picking also up on some interesting threads from last week that I think will be picked up in subsequent weeks is this notion of a completed life being defined by the person, a heavy emphasis on autonomy as a value. And I just want to note that culturally, religiously, personally, there are many people who look at the values that one would want to promote at the end of life differently, right? So somebody who looks at the values more in the context of a familial sort of clan relationship might put emphasis on different values than autonomy at the end of life. Or somebody who puts emphasis on experiencing food as care, or experiencing dependency as sort of the a societal obligation to care for dependent elders in a particular way, kind of putting a value on a society, sociocultural notion, would look at this very differently. And I just want to point that out, wanted to bring that up.
Yeah, I think that's fair.
But they're probably not the people calling Judy.
Well, it's a self-selected group that finds me, for sure. And that needs to be said, and I'm the first to acknowledge that. I don't find them, they find me. So, but it's interesting how word of mouth, as I say, I get calls from people all over the country who have somebody who remembered having been helped by whatever. So it's an interesting thing, and there's clearly a lot of interest in having these conversations, whether with Jessica in a critical care setting, very busy hospital, or with someone like me or others that do the work that I do. So I think that we need to acknowledge that these conversations need to take place, not ideally, Jessica, not in a time of crisis, right?
Right. Upstream. But I really think it's important to talk about this issue of, again, the cultural humility piece, the personal humility piece that we, and this is one of the things I have learned and continue to learn as part of the palliative care movement, is how to understand the incredible variation in preferences of all sorts that are out there. And the importance, I have a story in my book titled Filial Piety, and it's about a guy who was from an Asian culture and was coming to the end of his life, definite family patriarch, very, very gregarious guy who was shriveled and shrunken, and now his kidneys had failed. And he was adamant that he did not want dialysis. We had talked about it. He did not want dialysis no matter what. And I said, why? Tell me why not? Because, this is a man who could have lived now, for maybe a few more years with dialysis. He said, I have watched my friends. He described what he had seen, their nausea, their lethargy, they're just shriveling up. And he said, that is not who I am. And then as I continued this conversation with him and said, it sounds like you really don't want dialysis, I heard a sniffle. And I had forgotten that his grandson was in the room. He was sitting right next to us. And I just had been so focused on the patient that I forgot about the grandson. And this man turned to his son. He saw the tear. There was a tear running down his cheek. And he said, but I think I'm going to do dialysis. And you know what? It's easy for me to say, oh my gosh, this is not autonomy. And this guy was so clear about his goals. And it was, and the truth is, who am I to make that decision? This man was completely compos mentis, and he was clearly bringing in a variable that was so critically important in his life. And I think that humility that we must have is critical. And, I'm continuing to learn that.
Yeah. That's a lovely story. I have parents that think they know what their kids would want them to do, so they're not even going to have that conversation. And I say, actually, I think it might be a good idea to give them a chance to say what they think and what they feel and what they hope for you, rather than you deciding that so you're going to protect them from that conversation. Yeah.
Well, and sorry not to jump in, but you just brought something up for me, which is I really advocate strongly before disease strikes. We should all be having these conversations with our families. I mean, now I sort of have to walk the walk since I talk about this so much. And I actually ended up playing Go Wish with my son. And he was at the time he was 18. And it was so bizarre. And really, it was our first. We have conversations about death all the time because of my work. And my kids say, can we have like one dinner where we don't talk about death? But this time we actually played Go Wish, which many of you might know. GoWish.org is a good link for resources. It's a great way to get into having this conversation and starting the concept of who are you and what's important to you? How do you like to live your life? What would a completed life look like for you? And so my son, to my shock, my 18-year-old son, not the cleanest guy, tells me his top preference is to be kept clean. Now, I want to tell you that is gold. That is gold. And I would never, ever have known that about my son. And I really, it's funny. Oh, yeah, he doesn't. But you know what? The truth is, I wouldn't have known that. And if God forbid, my son was lying in a bed, unable to move, I think, and dying, I think that I would not have known that it would have been an act of love for him to have him be given sponge baths and be kept clean. It was only through clarifying that I now know that about him, and I'm so glad I do.
Yeah. It speaks to how, back to the relationship thing, that the building of a relationship, not only between provider and patient and family, but among family members, is an intervention in and of itself. Yes, you learned a piece of information, but it was a relationship building moment that's really nice.
Yeah, absolutely.
Yeah, thank you for that wonderful anecdote. Absolutely. So Jane Lowers asks, the word family comes up a lot here, kind of in relation to the idea of this relationship. So how do you advise people who want to get out in front of their end of life options, who don't have a logical caregiver or decision maker? What would you advise?
Judy, you want to go?
Huge problem. Both for people that feel that they have nobody that they can ask to be their healthcare agent, and people who have either outlived all of their friends or family members, or for me, more challenging are those who've sort of alienated everybody around them, and so they really have no social circle at all. I still encourage them to think about their own wishes and write them down, fill out a MOLST, talk to their healthcare provider. I mean, it can be so challenging for people that, are opposed to healthcare, don't believe in doctors, haven't been to a doctor, and still are recognizing that, oh my God, I may need to make some decisions here, and what do I do? So it's true. We assume that everybody has someone who cares about them and that they in turn care for, but that's not always the case. And those are people that are still worthy of, and in particular need of, guidance and information and support as much as we can. I really encourage these people to find some physician that they feel comfortable talking, or a nurse practitioner. I really am a big nurse practitioner for this kind of thing, because you can't, dying alone is the worst. It's absolutely the worst. But it's a horrible problem, and I don't have any brilliant solutions. What about you, Jessica?
Well, I mean, I'll just tell you a case that I had. Actually, I was doing a lot of volunteer telehealth in New York at the height of the surge, and we had a patient who was 94 at one of the public hospitals, 94 years old. No. She was 100. She was in her late 90s. I'm sorry, I don't remember exactly. And she was demented. She came in from a nursing home with COVID pneumonia. And there was nobody to talk to. We went all through the chart. We called the nursing home. There was no family member. And I called actually, and I started looking up online, and she had, I apologize. She had filled out a post. This is what happened. Filled out a post saying, do not intubate. And it was filled out probably 6 years ago. Mm-hmm. And her son had signed it. And now the team, this was a hospital that did not have a palliative care service, and they were panicking. They said, we think we're going to have to intubate her. But she has a pulse. And they said, but we can't get in touch with this person. And I said, it doesn't matter. She's got a pulse. But I started looking up, and it turned out that the son had died. I found it on the obituary site. He had died. The doctor, there was the name on the post. It was a social worker who had been at that, who is no longer there. I couldn't track her down. So my point is just that, it's what Judy says, that, it's not just a question of alienating or not having, it's also a question of outliving. And I think that for that reason, as we go forward and we're more tuned to the importance of clarifying our goals of care, making sure everybody who should knows about it. We really need to think about stories like this and really put it down on paper, as Judy says, and make sure that it is in the record, in the electronic medical record. Your primary care doctor knows about it, et cetera. But there are many ways to do it if we're planning upstream.
Yeah.
Excellent. Thank you. So another question related to the dementia directive, and this is a question targeted for Judy, but Hannah and Jessica, welcome to have you answer as well. This is from David Hoffman. He asks, how do you feel about a dementia directive that is triggered at FAST level 5? Should we be, quote unquote, recommending that the patient draft the advanced directive to activate at FAST level 6.5 or 7? What are your thoughts?
Well, again, this is all very new. I always encourage people that are thinking about completing one of these things to look at the data, the information that exists about the different stages of dementia, understanding that nobody goes through them at the same stage or the same way. But you know what? You get to decide what an intolerable existence would be for you. Who am I to say, well, that's just ridiculous, I think the problem is that it becomes more challenging to implement if you're expecting other people to be able to honor your choices. I think it gets harder to get a team of supporters, physicians, perhaps attorneys, family members, to support you at a time when you perhaps could still feed yourself or could still make some decisions. At stage 5, it depends on the person, right, Jessica? I mean, who the heck can say for sure? Yeah. Generally, what I'm talking about is advanced/terminal stage of dementia, which definitely is the 6 to 7 stage. We don't know how these things are going to be accepted or implemented. But again, who am I to say you can't possibly write that down? I mean, I would say to them, you may have real difficulties having this honored, and let's talk about that. Why are you choosing this? What's important about this? What are you trying to avoid? But it's early days, so I don't know. What would you say, Jessica?
I think all of this is early days, and I think it's just going to be continuing to push forward in the way that we're doing, having people like you available to do the work that you're doing, having people like me available to do the work that I'm doing, and hopefully this will all merge into new policies that make sense and that don't have to depend on a number or a stage, but that really can just be clear as time goes on. People will be having these robust conversations all through their course of their lives, like my son who's 18, just having them repeatedly so that as things close in and close down, it just becomes clear to everybody what needs to be done because they've had so much communication. I don't know. I know that's a mushy answer, but it's kind of how I see it.
I don't think there are any clear black and white bright lines here. I mean, I think that the more you talk about this and the more you recognize that other people might be very, very shocked and upset by seeing these kinds of documents. So we have to recognize that that's the clinical reality at this point, at this stage of where we are.
But I do think
Yes, sorry.
Well, I do think that as this becomes a movement, which it has been building, I would say, led by the palliative care movement, but as this becomes a movement and more people in the lay communities are reading about it and thinking about it and incorporating it into their lives, it will change. I mean, just like medical culture started changing from something I would say that was more humanistic to less in the 50s, 60s, 70s, 80s, I think this can also be a change that has really been pushed along by a big grassroots movement. And I do think that we will get somewhere new.
Wonderful. Thank you both. So Jocelyn Winslow asks, to get the conversation started perhaps on the other end of the age spectrum, how can we introduce the concept of having teenagers fill out advance directives when they first get their driver's licenses?
Great idea. Yeah.
Well, can I direct people to read an article I wrote called First Sex Ed, Then Death Ed? It's in the New York Times. It's a story. This is, to me, so obvious. We know, well, some states don't, but we mostly, I hope on this call, know that sex education works, right? It decreases unwanted pregnancies. It decreases, sexually transmitted diseases. It works. We have data going back, I think, from the 1800s on this issue. Why do we think that it's okay to teach kids about sex ed and not teach them about death ed? Why is death so much more taboo than sex? It's another life function. It's another bodily reality that you need to know how to manage and master in a sense. And so I feel very strongly that death education, like sex education, should be taught in high school. I think kids should graduate at the age of 18 with an advanced directive, their first advanced directive. I see no reason why not. I think that will change the conversation. Frequently now, I think kids, teenagers, people in their 20s are much less freaked out about death than we in our 50s, 60s, 70s are in some ways. Maybe as people get into the later years, they're more willing to talk about it again. But, how many people have you heard about in their 70s and 80s who have tried to talk to their kids in their 40s and 50s about death? And they're like, la, I don't want to talk to you. I don't want to. This is a really important communal change that will only happen if we, I think, normalize it to the point that we're starting to teach it at a time when people need to know about it. There are lots and lots of teenagers and people in their 20s and 30s who die. So why not?
I want to play a little devil's advocate here.
Okay.
I wonder about the usefulness of an advance directive completed by an 18-year-old, even 10 or 15 years later. The challenge here is two things, right? For one thing, young people think they're going to live forever. They're never going to die. And they also think, of course, I'd never want any kind of interventions. I'd never want this. I'm presuming you probably know more about this, Jessica, than I do. So I just want, of course, I'm in favor of more education rather than less. And the more you know about it and the options and the documents and all the rest of it. But I'm telling you, as a clinician, if somebody showed up, in a situation where they couldn't speak to me and the family brought out an advance directive that was completed when this person was 18 and they're now 30 or 40, I'd say, oh, please.
Okay, but let me play devil's advocate to you then.
All right.
Because an advance directive is no set of instructions. It's no set of specific instructions. A post form, which an 18-year-old probably would never, ever consider filling out, isn't. Yeah. But an advance directive is a high-level sense of who are you philosophically? Are you the kind of person who wants every single heartbeat until the end? Or are you the kind of person for whom there would be moments where you wouldn't want your life prolonged heroically? Yeah. That's really all the advance directive is asking.
I get that. And you think an 18-year-old can do that? Okay.
Yes, 100%. I have spoken to, I'm looking forward to everybody seeing the film on death education, but you will see we play this game Go Wish with we show the film Extremis to a bunch of kids, and there were tears. I'm not going to say there weren't some tears, and it was scary at some moments, but they were very able to process this and to wrap their heads around it and to really engage in conversations around this stuff. And I thought it was extremely productive. So I really, I stand firm on this.
Okay, all right.
It speaks to what you'd really want your patients to put in their advance directive, and sort of moving away from some of the boilerplate cookie cutter ones that we see that are can be less than useful, and to really make them documents that embody, a patient's preferences. We only have about 5 or 6 minutes left. I wanted to ask one more question of each of you before Sarah wraps, concludes our session today, which is this is heavy stuff. This has been a heavy 2 hours, no doubt. And, just to, if you can and are willing to reflect a little bit about the work's impact on you personally, and what your strategies are to gain support and to connect and to kind of refill your tank when it might be depleted from some of the heaviness of the work.
You go first, Jess.
Okay. Well, this is heavy. It's heavy, heavy, heavy. And there is a lot that there are moments where I'm really depleted. There are moments when I cry a lot. I come home and cry a lot. What I do to regenerate, and by the way, another thing, as a palliative care practitioner, particularly one who used to be in the intensive care unit, there is a certain professional tension and stress that it's not just the death and dying piece of it, it's the professional stress and tension that is a very big part of what is stressful. That sense of coming in as a palliative care doctor, when I'm used to being in the ICU doctor and now everyone listens to me, and I come in as a palliative care doctor and it's like, well, yeah, the palliative care said this, but we're going to do this. And this sense of feeling not like I'm part of the team and treading on eggshells. So that's another piece of the conflict and stress that really rears its head for me. I wrote a book which has a lot of this in it, a lot of my inner turmoil.
Yeah.
I got it out on the page. I came up with solutions for things that I think can make it better. I speak a lot. I try to unroof a lot of what's happening that most people will never see from the lay community until they're in a situation where they need to see it. I want them to see it earlier. I tell stories on film. I think that's the way I process it. I want to share it so that people are prepared. I cannot stand the moral distress of having a person stand in front of me who is suffering or watching their loved one suffer, and knowing that they are not equipped and have not gotten the information that I have about what could happen to them. So what I do is I spend a lot of time with them talking about it. I also want to tell stories for a larger audience so that more people understand what's going on behind the closed doors of the ICU and behind the doors of a person's home when they go home with hospice. Like, let's tell that story so that we can all reflect on it and do better.
I would just say that what I do is, the way I frame my interactions with patients and families, particularly patients, is I empower them with information. And that to me feels terrific. I'm giving them the information that they need in order to make decisions about what is a completed life for them. What are the values that they want to implement? I mean, I have friends and people that don't know me very well that say, oh my God, this must be so depressing. You're working. I say, no, actually, I don't find it depressing at all but again, I'm seeing people that are finding me. So they've done the heavy lifting they've stopped treatment. They've stopped the ICU. They've stopped maybe this one clinical trial will work. They're like, okay, I'm done with that crap. What can I do to have the least bad death possible? So I feel privileged, really privileged, to be able to have these conversations with people that seem to be ready to have them. And they tell me how helpful it is to know about this stuff so that they know ahead of time. And I can help them in ways that Jessica's talking about, to look at the decision points that are going to come up, and that they may need to give some thought to this ahead of time. They may need to talk to their physician a little bit more about. And if their physician says X, then you need to go back and suggest Y. And so we have a lot of those kinds of conversations. And again, as I say, I feel privileged to be able to do this work, and I'm glad that I continue to do it. I also believe, like Jessica does, in the importance of educating other clinicians. And I spend a lot of time writing and lecturing to nurses. Some of them are really very fearful about getting out of their boxes, and I want them to get out of their boxes and do better thinking about how they can meet their patients where they are. And so I write, but I write for nurses. I want to learn how to write more for a lay audience, because I think they benefit so much from the work that Jessica does so will you teach me how to do that, Jessica?
Yeah. Sure.
Well, it is all about relationships, I think. And so we see relationships forming on the screen right now, which is really nice. And this conversation and getting to work with all of you has, notched up my tank a little bit. So I thank you so much for that. And I'll turn it over to you.
Yes, you've been wonderful, Hannah. Thank you. And Sarah. You too.
Wonderful.
Thank you, Jessica and Judy and Hannah, so much. This has been a tremendous honor to sit here with you today. And to all of you in our audience, thank you so much for joining us and for submitting such wonderful and thought-provoking questions. We will make the questions available on our Slack discussion board. The link is here on the slide. And so we hope to keep the conversation running. Please keep these thoughts coming and questions coming. We'd love to continue the conversation. So please, a round of applause to our speakers and our moderator. And next week, we can look forward to a discussion on the case for objections and ethical concerns with Laura Ramsey and Daniel Slamacy in conversation moderated by Samuel Gorovitz. So we're very much looking forward to next week as well. And thank you all again for joining us today. It's been an honor to have you here. And please follow us on social media if you haven't already at Completed Life. Find us on our website as well, www.completedlife.org, and the hashtag Completed Life if you want to tag us. So thank you so much, and we'll see you next week.
Thank you.
Bye.